Hello, and thank you for joining us for our 2023 Total Joint Education for Same-Day Surgery, PACU, and the OSC. This video has been put together for those who are unable to attend our total joint classes that we held earlier this fall. Today, we are going to review our total joint metrics, cares of total knees, total hips, and total shoulders. And at the end, we'll briefly discuss the care of a hip fracture patient for those working in PACU. To jump right in, these are our 2023 total joint quality metrics. So when the surveyors are coming and they are checking to see how we are doing in our care of our total joint patients, this is essentially what they are really gauging us on and measuring us by for 2023 and into 2024. We will get our updated metrics in early to mid 2024, at which point we will get to do this education all over again. So as you can see here, the first one, total hip and total knee metrics are combined together. So we're looking at things like regional anesthetic, post-op ambulation, which is going to happen that day of procedure, at what point they are discharged home. And then there are two assessments or metrics that are used for our total hips and total knees that are done in the clinic. So it's good for us just to be aware of them. However, it's not something we're going to be responsible for. And those are the two functional assessment tests. For our total shoulders, they are also going to have that functional outcome assessment tool that will be done in the clinic. These patients are typically discharged home the same day, and so patients who are or aren't, that's something that we will be measured by. These patients will need a fall risk assessment completed on admission and then every shift. Now, when we look at that every shift, what's important to note is that also means every location, so to speak. So when they're in pre-op, we're going to do a fall risk assessment. When they get to PACU, we're going to do a fall risk assessment. When they get back to us in same-day surgery, we're going to do a fall risk assessment. With those total shoulders, they also want us checking CMS every 4 hours until there's return of normal sensation, and then once per shift. So those patients aren't with us long enough for us to do the per shift charting. So we'll just be checking CMS while they are in our care in same-day surgery in PACU. And then as far as our hip fractures go, this is very specific information to PACU, as we do not care for the hip fracture patients in same-day surgery. But what they're looking at with these patients is the amount of time it took for them to get from the ED into the actual OR. Whether they were mobilized post-operatively, so that's typically something that will happen on the floor. This is a big one for us, the patients that they need to receive their nerve block prior to surgical intervention. So this is something our MDAs should be aware of. However, as PACU staff, that's always something for us to be, hey, we know this is a metric, this is something we should be monitoring, and therefore ensuring that we are making sure this is happening and asking questions if it's not. With our hip fracture patients, they are also looking at intensive spirometry on admission, and then every single time that it's being done thereafter, making sure that we are documenting their IS. So for our same-day discharges for our total joint patients, what's nice with our total joint patients is it's about the same every single time, every single patient. Now, we obviously know there are outliers. Different patients have different needs, but at the end of the day, our routine, our function, our flow, the way that we take care of these patients is essentially the same patient to patient. So for our same-day discharges, it is ideal that they are planned prior to the day of surgery. Now, as we know that the provider does have the final say in that, and we do have some who come in that day of procedure and we're expecting them to go to the floor, and we get informed, oh no, they're actually going to be going home today. Remember, if that happens, it's very, very important that we are contacting PT and OT to ensure that they have them on their schedule and that they have the ability to see that patient that day. That is the responsibility of the primary nurse to be making that phone call and ensuring that this patient can actually get into therapies that day. Because obviously, if they can't get into therapy, they can't go home that day. So it's ideal that these would be planned prior. We would know in advance if there is same-day discharge. However, we do have those random one-offs. With our total knees, partial knees, total hips, and total shoulders, and then some of our revisions, those are typically going to be the patients that we see doing same-day discharges. We ideally will see these patients placed as first, second, or third cases because obviously we need them to get back. We need that spinal to wear off, and then for them to be able to complete their up to 2 hours of physical therapy and occupational therapy that will be happening prior to discharge. Now, with your total shoulders, those are the one exception, total shoulders do not always need to see PT and OT. You will see an order for both typically because that is a requirement of therapies. When one order goes in, the other one automatically goes in, but they typically will only need to be seen by one of the therapies. More often than not, that will be occupational therapy in order to pass them in order to go home. Everyone else, our hips and our knees, will have to pass both PT and OT before they are allowed to go home. On your typical patient, let's say our first case of the day, we should expect occupational therapy to come up at 1 o'clock. They will work with the patient in the room and do about 50% of their education in the room, at which point they will then take them down to the physical therapy gym where they will complete the rest of their occupational therapy and then move on to physical therapy. Expect those patients to be gone or kind of out of our care, so to speak, for about 2 hours. If the patient completes their therapy goals, they are medically stable and they've met all of their same-day discharges or discharge goals, they are able to discharge that day. Now, like I said, our workflow for these patients is going to be pretty straightforward. It's going to be about the same for every single patient. As we're looking at these, this workflow, notice this is the time frame that's given here is probably more consistent with that of the first and the second case patients. But when they first get to the floor, we're going to settle that patient on arrival. We're going to take their vital signs, offer them a snack, just like we would every other patient that comes back from PACU. Vital signs are to be taken at 15 minutes, at 30 minutes, and then every 2 hours after that. We want to begin incentive spirometry with these patients right away. It should be on their bedside. We should be educating them to do this every hour while they are awake. We'll order their celebration basket, or now what is their nothing bundt cakes, up through our dietary, so that will be available to them. And then here is an edit from when we originally did this. So we used to do the express meals. Our patients are now able to order meals through the kitchen. What's very, very important though is that we're ordering that meal early. It can take up to 45 minutes for that meal from the time the order gets put in. It could take up to 45 minutes for that meal to make it to our unit. So if we would like them to be eating around 11, 12 o'clock, that patient, we need to be putting in that order as soon as that patient gets back to us. Now, our patients, we're going to talk about this in greater detail later on, but our patients are on a very strict pain medication regimen, one that we are going to start as soon as they come back to us. So at noon, we will give their scheduled Tylenol. If they need additional pain medication to pre-medicate prior to going to PT, our first line of defense is going to be IV Toradol. Second line of defense would then be the oxycodone if needed. Those are the two PRN pain medications that have been given to us in our order sets. We also want to saline lock their IV at that time because we do not want them going down to therapies with the long cord and bag. PT and OT are typically going to arrive around 1 o'clock to begin their treatment. When the patient gets back to us at 3 o'clock, we want to give that tramadol so that they stay on the correct schedule. Now, it's very important to talk about these post-op antibiotics. Patients will receive a dose in the preoperative dose and then a dose in the OR as well. You do not delay discharge for waiting for an antibiotic. What the research has shown us is that it is the preoperative and intraoperative antibiotic that is the most effective in decreasing and preventing infection in the total joint patient. In fact, they have found that post-op, while it's not going to hurt anything, it actually doesn't really increase or decrease the incidence of infection. So if your patient gets back to you at 3 o'clock or 4 o'clock and they're not scheduled to have their post-op antibiotic till 5. You should not hold them until 5 o'clock in order to give that medication. Just go ahead and send them home without the post-op antibiotic. Now, we have a couple of goals for our same-day surgery total joints. The first is incentive spirometry. We want to start this immediately post-operatively and then educate them to be doing it frequently. They put here in the parameters as every 2 hours while awake. It doesn't hurt to have them do it every hour if we need to. With the spinal anesthesia, all of these patients will be receiving spinal anesthesia, the total hips and the total knees. We need to document our CMS every 4 hours until their return to normal sensation and movement. Now, in same-day surgery, we actually do this more frequently. So this is the minimum requirement. We actually check it every hour. So when that patient comes back to you, you need to be checking the spinal site, making sure that that site looks good, and then checking CMS every hour until it has fully resolved. At which point they would be capable to get up, go to the bathroom if they needed to. That's also the point that they would be cleared to begin doing therapies. And then as with every one of our patients, we need to be reassessing all PR and pain medication. If it's PO within an hour, if it is IV within 30 minutes of administration. So incisional care, as we all know, each of our doctors are slightly different in the type of care that they provide, or the type of incisional care that they want us to be educating the patient to provide to themselves. One thing that is going to be consistent across the board for every single patient, other than the Aquacels, is that all dressings need to be changed post-op day 1. So our hips and our knees are going to come back to us with a large ACE bandage around their incision, around that extremity. They need to take that ACE bandage off the next day. They need to take their dressing off the next day, inspect that wound site, and then go ahead and put new dressings on. So we should be sending them home with some additional supplies, gauze, tape, whatever they need in order to be redressing that incision the next day. The only incision that is, or dressing that is going to stay on is the Aquacel, which is that large like tape dressing that only Dr. Hughes uses, or the Provena, which is that kind of wound vac that Dr. Hughes uses very, very rarely. Like we said, we need to take that ACE bandage off the next day, apply gauze, ABD, Tubigrip, or edema wear. It depends on who the provider is. And then, yeah, just provide them with that education. They should be sent home with an additional dressing change set. After that one, it is really their responsibility to provide those for themselves at home. So we can send them home with gauze, we can send them home with tape, whatever it is that they need, but really should just be providing one change worth. And then we'll go through that zoning tool. Now, every single one of our total joint patients has gone through a total joint class. They have the option to attend either live in person or to attend that class online. If they do the online self-paced course, they actually do have to submit an exam or a test at the end of it to ensure that they fully understand all of the information. So they should be well versed in what the zoning tool is, and we will discuss that with them and just kind of remind them, hey, if you're seeing these symptoms, you're in the green zone. If you're seeing these symptoms, you're in the yellow. These symptoms, you are in the red. And then it gives specific instructions on what to do based off of which zone they fall within. Now, as with all incisions, no soaking the incisions. This is not our zone tool. We didn't have a digital version that I could put in here, but this is an example of what a zone tool would look like. So it tells them what symptoms fall within a green zone, which means, hey, this is really good, we're good to go, and what to do about that. If they fall within a yellow zone, they need to be cautious, and what's the protocol for if they're running into these problems. If they're in a red zone, how do they respond to that? They all have a zone tool in the packets that are given to them in their total joint class. So once again, we're not giving them an additional tool. We're simply reiterating education they've already received and pointing them back to the education that they have already received and the tools that they've already been given. You'll notice in our AVS and our dot phrase that we use for our total joint patients, we actually include this in there now, and it's the post-op instructions for wound care by provider. So depending on who your provider is, obviously all of these will auto flow into that AVS. Typically what I like to do is just delete all the docs that don't apply to that patient. Why give them more than they need? If they're just a Dr. Carpenter patient, then you can get rid of Canham, Hughes, and O'Regan's information and just have this Dr. Carpenter stuff and the for all patient information, just to make it a little bit clearer for them. But once again, when you enter the dot phrase for our total joints, this will automatically be included within that. Now we'll talk very quickly about the Provena and the Aquacel. Provena we almost never see. Provena is more like almost kind of like a wound vac in a way. It is a wound vac actually. If we see those, there is additional education that is in our education binder back in the post-op area that kind of talks about what Provena is. I did just recently send a video out to all of our staff as well, just some troubleshooting with Provena. If you run into a patient who is going to have one of these, Kelsey Schneider, she is the Total Joint Program Navigator. She is a great resource and someone who we should call, as she'll come up and do the education with the patients on that Provena pump. The Aquacel dressing is the dressing you see over here. Dr. Hughes is the only one who uses this. It is a waterproof dressing. We can get them from CPD if for some reason we ever needed a replacement. Typically what we would see if we needed a replacement is one that gets completely saturated in blood and we're asked to change the dressing. Call CPD. They will send you an additional one. We do not stock them on the unit. And then the Aquacel actually stays on for 7 days. So in these cases, these patients would not be changing their dressing the next day. They would leave it in place for 7 days and then remove it. They are not sent home with an additional Aquacel. If they are at home and they believe that that dressing needs to be changed, that it's becoming that saturated, that would be an indicator that they needed to contact their provider anyway, because that is too much drainage from that incision. So pain management for our total joint patients. We want to be very clear in our education for our patients on pain management. It is very structured. It is the same for every single patient, and they're on a pretty strict regimen on how we manage their pain. So let's see if here we go. This is the better example. So all of the patients are going to go home on scheduled Tylenol. That scheduled Tylenol is going to be given at noon, 6 p.m., midnight, 6 a.m. Tramadol is also going to be scheduled every 6 hours. They will receive that at 3, 9, 3, and 9. We want to instruct them to be setting alarms in their phones or setting a reminder so that even if their pain is very low, for the first 3 days, they need to be taking Tylenol and Tramadol around the clock. They will be sent home with oxycodone tablets, 5 milligram tablets. They can take 1 to 2 of those every 4 to 6 hours for breakthrough pain. So if the Tylenol and Tramadol is not enough for them at home, they can take additional oxycodone as they need to. These patients are also going to be going home these are going to be prescriptions that will be filled for them. Some over the counter, some are actually filled with their pharmacy, but the Mobic they'll start taking at bedtime the day of the procedure. They'll start taking a baby aspirin 2 times a day. Pepcid starting at bedtime the night of the procedure, and Senna 2 times a day starting the night of the procedure. Oh, guys, not letting me go backwards. So some of the questions that we will sometimes receive about about pain management for total joints. So when they are on the floor with us, we're going to start this right away. We're going to give them their Tylenol at noon. We're going to give them their Tramadol at 3. Prior to going down to PT or OT, if you feel that your patient needs additional pain management prior to that, our first line of defense is going to be IV Toradol, and we can give that at any time. Now, Toradol is included in the total joint mixture. So when you go to give a dose of IV Toradol, you are going to receive a warning that it just says, hey, like this has already been given. The medication is actually absorbed very differently. So the total joint mixture actually gets injected right into that joint. It's intraocular, is I believe how they say that. And it gets absorbed completely differently than by giving it IV. So even though they receive that in the total joint mixture, it is actually more than appropriate and perfectly safe and okay for them to receive the Toradol post-operatively as well via the IV route. So that is a warning or a risk that you can override to give them that IV Toradol. If their pain, when we were looking at our orders, the IV Toradol is ordered PRN for a moderate pain. So it's like a 4 to a 6. Your oxycodone, which is a 5 milligram tablet, is ordered for the severe pain 6 or greater. Now keep in mind, these are both PRN medications. You are a nurse with a nursing degree, in which case you can use your nursing judgment on those. We have been asked, though, that you do start with the Toradol. If Toradol is not enough, then move to the oxycodone. Now, you know your patient. Every patient is different. If your patient is seeming pretty uncomfortable with very little movement and you're like, hey, you know what, we're getting ready to go to PTOT, I think we need to just jump to the big guns, that's more than appropriate for you to do that. Important to remember with our Tramadol patients, if they are on SSRIs or SSNRIs, they cannot take the Tramadol. Also, if they have a history of renal dysfunction, they cannot take the Tramadol. So this is something our providers should be recognizing and not ordering. However, we want to be that double check. You know, the Swiss cheese effect, it can fall through lots of holes before it gets to us. So that's just something we should be cognizant of. As with all of our pain medications, we want to be reassessing oral pain pills within an hour, IV pain medications within 30 minutes. We're going to talk about the difference here between our two different types of total hip replacements. So the first, and it's probably the easiest, is our anterior hip replacement. So currently, Dr. Hughes is the only ortho provider that is doing this approach. The beautiful thing about this approach is these patients are not on the standard hip precautions that we're used to hearing about. Really, the only movement precautions these patients have is that they cannot stomp and they cannot jump. They actually can turn on to the operative side if they can tolerate it, and these will have that Aquacel dressing on as well. So your anterior hip is going to be your simpler hip as far as mobility is concerned. Your posterior hip repair, our total hip replacement, is going to be done by all of our other providers typically. And these are going to be the ones that are at that increased risk for that dislocation for the next 3 months. And so that is where we want to kind of talk with them about these no-nos. No bending past 90 degrees, no crossing of the legs, no no twisting. These patients typically are going to come back with a foam like insert between their legs that kind of helps to prevent that crossing and twisting as well, just as an added precaution. Elective posterior hips are typically going to be done by Dr. Carpenter, and he is going to typically use staples with that procedure, which will need to be covered for showering. All right, we've kind of already talked about these, so I'm just going to kind of skip past some of this. This has just more to do with our performance measures or our metrics. Now, with our total shoulders, these guys are a little bit different. They kind of come in and out quite a bit faster than our total hips and our total knees because they don't have a spinal that needs to wear off per se, and they don't have to go through as much of the therapies. So typically our OT is going to see these patients in the early afternoon. Now, if this patient gets back to you and within an hour, hey, we're doing really good, we're eating, we're drinking, we're up, we're moving, we're feeling good, you can always call OT and let them know that the patient is ready early. That way, if they're available to come early, they sure can, because then that patient can pass and discharge home a little bit sooner. PT is always going to be consulted on these patients. However, it's very rare that PT would actually need to see these patients. There's just a Dr. Carpenter or Canham was explaining to me that PT actually requires that when you put in the OT appointment for the total shoulders, they also require them to put in the PT consult as well. However, typically only OT is going to be the one to come up. Kind of confusing, I know. With these patients, we want to be monitoring their CMS. These guys are going to have that nerve block in place, and so they are going to have that dead arm in that immobilizer, so it's very important that we're monitoring CMS and return of sensation, even though that return of sensation is most likely not going to occur while they are with us. Some of the things we want to just educate them on, and they'll talk to them about, OT will talk to them about this as well, is just reminding them that as the arm swells, the arm straps on those immobilizers, the one that's right above the elbow and at the wrist, those might need to be adjusted a little bit more frequently so that the patient is, because while the swelling's happening, we don't want them cutting off circulation. So something for them to be looking at. And then they're going to be there doing their gentle range of motion with that hand, wrist, and elbow 4 times a day. This is something OT will review with them and will give them a handout for. Icing, obviously extremely important for these patients as well, as it would be with any total joint. This is just a review of the total joint performance measures, which we have already discussed. All right, so nursing responsibilities. So our patients, like I said, have already been through the total joint class. They have received what they call the guidebook. It's a folder that they get. Basically, we want to instruct them that this is their total joint Bible. This is going to tell them everything they need to know. If they have questions, if they have concerns, if they're not sure what to do, that is the #1 place that they need to look. We are not responsible for re-educating them on the information that they have already learned. We do not need to go through that folder with them. We are going to hit the high notes before they go home. So for our discharge instructions for these total joint patients, always, always, always refer them back to that guidebook. Remind them of the zone tool, review that zone tool with them. When it comes to discharge, we only use the total joint dot phrase. Do not add any additional education. Do not add PC post. Do not do the nurse hotline, nothing. Do not add anything other than this dot phrase right here, .SDS DC info. When that populates at the very top, you're going to see those medications we previously discussed. You're going to want to go in there and enter the times that the next time they can take those medications, so those patients are aware. This dot phrase is going to include medication information, like I said, that we will update. It's also going to include the information about wound care, so you can review that with them as just a nice refresher prior to going home. And then we always want to encourage the coach to participate, or so the support person. So every single one of our joint replacement patients, almost said recipients, patients, are instructed to have a family member, friend come with them. That coach has been through the total joint class with them, and it is the expectation that that coach spends the day with them here in same-day surgery. It is also the expectation that that coach goes with them to PT and OT. So when you're educating the family, I always like to give them like a window, like, hey, you know what, 11 o'clock noon is a good time for you to go and grab some lunch, but you need to be back here by 1 o'clock because that is when PT or OT will be up here, and it's important that you participate in those therapies with them today. All right, so that is everything about our total joints. We're going to very quickly talk about hip fractures. This is information that's really more pertinent to PACU. There's not a lot that we necessarily do in PACU that's different for hip fractures, but it's very important that our PACU staff are knowledgeable about this type of patient, the type of care that's expected, and the things that we're measured on with these patients, so that if you're ever asked, you can speak to it. So all these patients will receive a hip fracture guidebook when they are admitted to the floor, and there is special education that they will go home with. Now, they do need to be mobilized within 12 hours post-PACU. So that can be as simple as a dangle. Now, the reason why I'm stressing this here is if for some reason we're holding patients in the PACU because beds are not available and you have a hip fracture that's been with you for more than 12 hours, it's important that you are at least doing a dangle with them because that's something that we are going to be measured on. These patients need to start incentive spirometry right after, so starting right away in PACU when they're alert and awake and able to do so. It needs to be done hourly and needs to be documented. As you can see, several of these other things are more specific to the floor. The TAPS system is something that we can order up. It's a turning system, and it's a system that we can utilize for lifting, scooting, moving patients. So if that's something that you feel that is needed for your patient, a TAP system can be ordered up for us. I believe we get it through CPD, but clarify that one with Lynn just to be on the safe side. Let's see here. Some of this does not apply to us, so we're going to skip over that part. The performance measures, like we talked about. So the things that they're going to be looking at is the time from admission to the OR, so from the time they get to the ED to the time they get to the operating room, that first mobilization happens within 12 hours or less. Now, this is the one that does pertain to us because typically we're going to see this in our area if they happen to go to pre-op hold prior to going to the OR, that the patient receives the nerve block prior to surgical intervention. So once again, this is a responsibility of the MDA, but important for us to be knowledgeable about so that we are able to advocate for those patients if we need to. And then incentive spirometry, once again, needs to be documented on admission. And then we need to be doing that regularly with them hourly afterwards, once they are alert and awake to be able to do so. So that is our 2023 total joint education. Those of you who are watching this via video, please come and find me, Tabby, after you have finished this, and we will go through the competency that you will need to sign off. We will do this education annually, so please be expecting it again in the future. Thank you for joining us today. And if you have any questions, comments, concerns, please don't hesitate to reach out to me. Email is probably the best way to get those questions answered. Have a wonderful rest of your day.